Tare Bill, I met more than 40 years ago. I have known him for more than 40 years ago, since 1981, I think, yes, when he came to Lagos to do his NYSC. I had just returned from the UK at that time, having just passed the MRCP exam. And he was posted to work in the organization where I was working. And we interacted a lot. He was a very active young man then. We interacted a lot, and I told him a lot about the training I had in the UK. I think he probably was thinking of being a pediatrician at that time already. But I was not surprised when, after he finished his residency, he found his way to the UK. Perhaps because of all the things I've told him about the training in the UK. I don't know, but I'm so delighted that since then he has done so well. He has broken all boundaries, and I'm so proud to have to host him at this meeting today. So I welcome him especially, and I look forward to a very exciting and informative lecture from him on this occasion. I also welcome Professor Esegbe, all the way from Makurdi in Benue State, for accepting to moderate the session. On that note, I welcome everyone to this meeting. It's an important topic for all pediatricians, especially those in private practice, who are frequently the first port of call for mothers or carers who are looking for expert opinion about things that they have observed about their children that don't really add up to them. So it is important that we are at the cutting edge so that we can help these mothers and carers and give them the proper advice. Some of these issues that they bring, some of them are self-limiting and they need to be reassured about. Others need intervention. And the earlier the intervention, the better. So it is important that the first person that they see is able to diagnose and recognize what is happening. So it is therefore so important, the lecture today, for us to be able to have guidelines and to be able to guide us in reaching that kind of conclusion. So without much ado, I will hand over back to to Dr. Eletu to continue with the program. So welcome everybody. Thank you.
Thank you very much, sir. Now we have seen Dr. Bill's face, so we know that we are ready. So I'll just hand over to Dr. Esegbe as the moderator for today. Over to you, Edwin.
Thank you very much, sir. Thank you. Good evening, distinguished, good day, distinguished participants. On behalf of the Guild of Pediatricians in Private Practice, I want to welcome everyone to this very interesting discourse. Dr. Madani Lawa has already talked about the person, but I just want to re-echo some of the things he has said about the presenter. He has contributed and he still continues to contribute to the development of neurodevelopmental pediatrics in Nigeria. And as president of the Child Neurology Society of Nigeria, I cannot thank him enough. He's contributed in seminars, sent materials, and we are grateful for his continuous support of pediatric neurology and neurodevelopmental pediatrics in Nigeria. He has served not just the country, but he has also served the region. I'm talking about the West African region as a regional advisor for the Royal College of Child Health and Pediatrics. Today, he'll be telling us about investigating developmental delay by the pediatrician in general practice. I'm sure it's going to be an exciting discourse. So on behalf of the Guild, and indeed all participants, I would like to welcome Dr. Tare. Dr. Tare, sir.
You need to unmute yourself, Dr. B. We can't hear you.
Can you hear me now?
Yes.
Okay. It's a privilege for me to be hosted by my master and teacher, Dr. Femi Mobolaji Lawal. I was his apprentice in 1980-81 during my youth service. When he came back from the UK with his MRCP, my goal in life was to obtain this MRCP and just be like Femi Mobolaji Lawal. I'm glad I was able to achieve those goals. Today, I'll be talking about the investigation of developmental delay and sorry. Just trying to get the slides in order.
Do you want us to project for you?
Yes, please, you can project for me. I have the slide. Yeah, can I have the first slide? Yes, good. Thank you.
You can go ahead.
Okay. Right, this afternoon, I'll be talking about my objectives, introduction, definition of developmental delay, prevalence, etiology, assessment, history, physical examination, red flags, warning sign, first line investigation, second line investigation, role of multidisciplinary teams, educational support, recommendations, limitations, and conclusion. My objective to share information and knowledge about the recognition and investigation of children with developmental delay and intellectual disability amongst pediatricians in private practice in Nigeria, and also to provide a guide to what investigation to do in case of DD and ID, which includes blood tests, urine tests, imaging, neurophysiology, genetics, EEG, muscle biopsy, and the rest. And when to refer to the neurodisability pediatrician, neurologist, or clinical geneticist. And throughout the talk, I'll be discussing recommended UK guidelines for investigating DD and ID, and the role of MDTs in providing support and educational and social welfare support. Global developmental delay and intellectual disability are common reasons for diagnostic assessment by pediatricians. In fact, they form the largest proportion of workload among the community pediatricians in the UK. Early diagnosis and provision of appropriate support would improve the outcome for most of these children, particularly those that there's a clear etiological diagnosis. There's a multiplicity of possible causes, many of which are genetic. Genetic causes account for 25% to 50% of the cases. And that's why it's important to have a very good genetics lab when investigating children with developmental delay and intellectual disability. A detailed history and physical examination will give you a clue about diagnosis in up to 40% of cases, 40% of cases. Global developmental delay is defined as significant functional delay in two or more developmental domains. Gross motor, fine motor and vision, speech, language and hearing, personal, social and self-care social skills and cognition. Specific developmental delay affects only one domain. DD and ID reflect on parental emphasis on the child's attainment of developmental competence and skills. Global developmental delay applies to children who are 5 years and below. And when they are older than 5, we talk about intellectual disability, which has replaced the old term mental retardation. A mental ID reflects human capacity to think abstractly and plan. Prevalence, 2 to 3% of the population in the UK have global developmental delay or intellectual disability. 2/3 mild to moderate and 1/3 severe to profound. Worldwide, intellectual disability has a prevalence of 0.63%. In Nigeria, intellectual disability has a prevalence of between 4.4 to 13.6%. Ejiliogu and Utok 13%, Tuleji and Izuara 7%, Lagunju and Okafor 4.5%, Frank Breeze and Aliko 7.2%. Classification: congenital or acquired, mild, moderate, severe. The genetic groups are classified into metabolic or non-metabolic, and some will classify them under syndromic and non-syndromic. Concerns are usually raised by carers or parents about the developmental progress or specific behavior of these children. In the UK, when the child is born, there's a thorough examination by the senior health officer who records general examination of the newborn, heart murmur, hips stable, testes descended, red reflex, and other things there. And on the 5th day, the child has the neonatal blood spot done, which screens for cystic fibrosis, phenylketonuria, Tare function tests, and some other metabolic tests, 7 of them in total. The child also has the neonatal hearing test within the next 2 or 3 weeks. And from 4 months, the health visitor carries out the ages and stages assessment using the ages and stages questionnaire 1 to 3. And between 9 and 12 months, the ages and stages assessment identifies delay in gross motor skills, and the check at 2.5 years identifies those with delay in receptive or expressive speech and possible social communication difficulties, such as autism. Now, child minders, the nursery and preschool regularly assess the children. They refer these children with a plateau in their development or regression to the health visitor or the community pediatric team or the GP. careful evaluation of the costs of this cost of the developmental delay or intellectual disability can be found in about 50 to 70% of cases. Dr. Hart in Sheffield Children's Hospital had one of the most revealing studies about the value of investigations done for developmental delay. 699 children were recruited into this study over a couple of years, and the age ranged between 3 months and 11 years. Average age was about 2 years, 8 months. Etiological diagnosis was made in 55%. MRI contributed to the diagnosis in 23.1%. That was the investigation that was most useful, the MRI. Macro-array CGH, which is the standard genetic test, first-line genetic test done in the UK, increased the diagnosis in about 11.5% of patients. Fragile X, testing for Fragile X increased the diagnosis in 0.9%, plasma amino acids in 1.2%, organic acids in 0.9%, and Tare function test in 0.5%. But you must understand that in the UK, every newborn has a Tare function test. Okay. Most other tests, ISA, carnitine, prosa, biotinidase, lead, and the rest, did not identify one single case. So they are not cost effective because of their very low yield. Now we talk about the causes of global delay, genetic or syndromic. The genetic causes identified in 20% of those without neurological signs, dysmorphic features, or family history. The ones easily identified are those with symptoms like Down syndromes, Turner syndrome, Williams syndromes. Genetic causes are less obvious in early childhood in Fragile X, the George syndrome, Angelman, Sotos, Reds, maternal fetal ketonuria, mucopolysaccharidosis, Duchenne muscular dystrophy, tuberous sclerosis, NF type 1, and subtelomeric deletions. Metabolic causes are identified in only 1% of those without neurological signs, dysmorphic features, or family history. There is a nationwide universal screening, which I just talked about, with screens for phenylketonuria, medium chain, MCAD, medium chain ISA-CoA dehydrogenase deficiency, and urea enzyme, urea cycle disorders. Endocrine, the main thing is the congenital hypothyroidism or pseudo-hypoparathyroidism. Traumatic, acute brain injury following child abuse, subdural hemorrhages with retinal hemorrhages, fractures, and the rest. Environmental causes are a very important case, particularly children who have suffered neglect, abuse, and have grown up in environments where there's much stimulation. When these children are removed from those environments, you notice a catch-up in their development. And that's where the social services and the safeguarding team come to play here. Cerebral malformations, neural migration disorder, or absence of corpus callosum, which usually exhibit typically with motor disorder, delay in walking, delay in sitting, and other motor disorders. Infections are important cause. Perinatal infections, rubella, CMV, HIV, neonatal meningitis, and toxins, maternal alcohol and drugs in pregnancy. So the next is the assessment. This is very important, particularly in an environment like Nigeria, where you have paucity of genetic investigation, paucity of pediatric anesthetists who are essential in those children under 5 having the head MRI scan. So a meticulous history, so important, I'll talk about it in a minute. Meticulous physical examination. In the UK, we have the Red Book, which contains everything about the pregnancy, the delivery, the weight of the child, ABGA scores, the examination on first day, the ASQs at different age groups, at different ages, everything in the book there. So if you have a good look at the Red Book, if a 2-year-old comes to you, you look at the Red Book, you can clearly see, oh, this child is behind in this domain, he was behind in that domain, or he has global delay, even before you start asking your questions. We need to have such a book in Nigeria. And I understand Professor Esegbe and the Child Neurology Society of Nigeria are likely to launch one at the next PAN conference in Lagos. The GP records are good as well. And you use validated diagnostics tool for your assessment. I'll talk about them in a second. You also need input from academic setting, play groups, nursery, primary school, secondary school. And I'll talk about these other tests you do. Consider safeguarding at every opportunity, consider social care input, and know when to refer to a neurologist and when to refer to a neurodisability pediatrician and when to refer to a clinical geneticist. History. You need a contemporaneous history of any smoking, drinking alcohol in pregnancy, other drugs ingested, and at what gestational ages. Some drugs, some conditions are associated with maternal drug ingestion, the fecal alcohol syndrome disease. Even a small amount of alcohol ingested by the mother at any time of pregnancy, particularly the first trimester, has been shown to be associated with fetal alcohol syndrome with typical dysmorphology and learning difficulties. Perinatal and postnatal history are essential. Prematurity, infection, death, asphyxia, neonatal jaundice, seizures, encephalopathy, aposic, ischemic encephalopathy, risk factors for hearing loss like neonatal meningitis or meningitis in the first year, or impaired vision in extreme prematurity. Family history is very important. Family history of consanguinity, which are making you thinking of genetic factors. Family history of learning difficulties, they run in family. Attendance of special school by the parents will give you an idea that the particular parent had learning difficulties. And family history of neurodevelopmental conditions, autism particularly, ADHD. Find out about each sibling's, their educational status, the health conditions of each sibling. Does any of the siblings attend the special school? When I say special school, school for children with learning difficulties, or is any child receiving extra academic support in school. Find out about miscarriages, stillbirths, and do a developmental, go through the developmental milestone for these children. I've forwarded to Dr. Eletu my University of Bristol lecture talk on normal development and abnormal development, which is accompanied by video demonstration at different ages. Is invaluable. So every participant should have a copy in his bookcase. So with that, once you go through it often, then you can do the development assessment like I do without referring to any book or anything there. Also, parental concern regarding development is very important. Now, mothers who've had many children, when you see a child not catching up like the others, they know. So always take parental concerns very seriously. Also concerns from the child minder, nursery, health visitor, or school. Like I said, inspect the red book, look at the ASQ reports from the health visitors. Examination. Look at the general appearance of the child, look at the facies. In children with mucopolysaccharidosis, they have the cause facies, Horler syndrome, Hunter syndrome, Sanfilippo syndrome, mucopolysaccharidosis type 3. The skin is very important. Look for neurocutaneous markers, Kapfe, Ole, spots, in neurofibromatosis type 1, very large Kapfe spots with ragged edges in Marcon-Albright syndrome, hypopigmented macles and chagrin patch in tuberous sclerosis, adenoma sebaceum in NF type 1, serpentiginous green brown skin lesion in a girl in incontinenti pigmenti or hypomelanosis hypomelanosis of Ito, the differential diagnosis, photosensitivity, corneal scarring, developmental delay in xeroderma pigmentosum. Neoplasmosis is particularly important, particularly when you have a child with Kapfe-Ole spots, fibroneuroma, seizures, pseudoarthrosis, perangular leach nodules, and intellectual disability. Sturge-Weber syndrome, flat, spot 1, red to brown, lesion on the face, seizures with intellectual difficulties. Also important to look at the hair, kinky hair, in Menkes kinky hair disease. The weight is important, the height is important, the weight and height should be plotted on growth chart. The head circumference is important. The head circumference should be plotted on a growth chart. And if the head circumference is less than 0.4 centile for age and sex, this child has macrocephaly. Excessive heights, consider Soto syndrome. Those children with Sotos have very excessive height and weight, and they are associated with marked developmental delay. Homocystinuria, very tall heights, downward displacement of the lens, Klinefelter syndrome, very tall height, upward displacement of the lens with other cardiac anomalies. Triple S syndrome, very interesting. I've come in my 43-year pediatric practice, I've come across 2 cases of triple S syndrome, and they almost fooled me. This child had no dysmorphic features. Only problem was the poor academic achievement in school. When the child I first saw the child when the child was referred late at about 10 years of age. I looked at the growth chart and I saw a marked trajectory in the height of this child. This child was pre-pubertal with a marked trajectory in height. That's one of the hallmarks, excessive height when they are between 9 and 14 years, and profound intellectual difficulties. Microarray CGH, the chromosomal analysis was XXX, triple X syndrome. Always remember that. And many other systems were involved in this girl. She had been referred to the endocrinologist, she had been referred to other specialists in pediatrics before she came to us. Short stature, Down syndrome, Turner's, chondrodysplasias, microcephaly, X-linked autosomal dominant gene, exposure to toxin, infection, CMV, rubella, varicella, Zika, toxoplasmosis. So dysmorphic features look for ridges at the sutures, apart, Crouzon's, Carpenter syndrome. Look at abnormalities of the ears, abnormality of the eyes, almond-shaped eyes in Prader-Willi syndrome, coloboma in DiGeorge syndrome, absent red reflex in cataracts. Look at the nails, look at the genitals, look at the hands for syndactyly, polydactyly. If you don't look at it, you won't find it. Look at the feet as well, wide space, toes, look at the digits, look for anemia. Chronic anemia itself, without any other thing, can cause a delay in development. So assessment standardized tools for assessment. ASQ3 in Nigeria, there's the Ibadan Simplified Developmental Screen Chart developed by Professor Lagunjo and co. The schedule of growing skill 2, which I planned to demonstrate at the next PAN conference, if there's a room for it. Productivity test is it takes a very long time to do. It takes about an hour to do. And then the Bailey's Infant Neurodevelopmental Screen, which is very good for the under 4s. There should be surveillance about growth at every visit. Any child not reaching milestone and surveillance or has known high-risk medical conditions or biological factor or parental concern should be seen for neurodevelopmental assessment. Red flags at any age: loss of developmental skill, regression, parental or professional concern about visual impairment, not fixing or not following, hearing loss or not responding to sounds, head circumference greater than 99 centile or less than 0.4 centile, or the head circumference crossing 2 centile charts, either downwards or upwards in a short period, abnormal muscle tone, asymmetry in movement, age specific, no social smile at 6 to 8 weeks, persistence of primitive reflexes at 6 to 8 months, not reaching for objects by 6 months, not sitting and supported by 12 months, no single words by 18 months, still casting and mouthing at 18 months, persistent toe walking, hand preference before 2 years, not sharing interest by 2 years, not running by 2.5 years. So first line investigation. Always consider assessment of vision and hearing. Genetics. In the UK, the first line investigation is the macroarray CGH. It picks up most cases of genetic conditions, but it doesn't pick up Fragile X. it doesn't pick up Rett syndrome. So we have to do separate tests for fragile, separate tests for Rett and for Rett syndrome as well. And the recommended first-line blood tests are CK for the muscular dystrophies, lactate, ammonia, plasma amino acids, full block and ferritin, Tare function test, lead, if there's a history of pica, and a urine for organic acids. Now, the second line tests are tests that are directed towards a diagnosis, to a possible diagnosis. You don't do blind requests for this other second line test. So if there's a family history of metabolic condition, family history of consanguinity, regression, organomegaly, cause fissures, seizures, abnormal head size, episodic decomposition, congenital ataxia, sensory impairment, including glue here, consider doing these metabolic tests. Blood tests include lactate, serum or CSF lactate, ammonia, amino acids, lead, very long chain fatty acids, carnitine. Dr. Hart's study showed the very low yield of carnitine profiles, very low yield of biotinidase, homocysteine, transferrin, white cell enzymes, or 7-hydroxycholesterol. Urine tests, urine organic acids, glycosaminoglycans for the mucopolysaccharidosis and oligosaccharides. Now, neuroimaging, like I said, has the highest yield, about 25 to 27%. You consider doing neuroimages under the following conditions: abnormal head size crossing 2 centile charts, or markedly greater than 99.6 centile or less than 0.4 centile, or in general, less than 2.5 standard deviations below the mean. Seizures, particularly focal seizures. So seizures, particularly focal seizures, neurological signs, cranial nerve abnormalities, cerebral palsies, neurocognitive signs, dysmorphic features, arthrogryposis, optic atrophy, nystagmus, and regression in development. MRI is the first choice, but for certain conditions, the CT of the bone, CT will be good for when you want to check the bone, particularly in the chondral dysplasias, or when you're thinking about calcifications, like in toxoplasmosis. MRI spectrometry is particularly good for picking up creatine deficiency. For neurophysiology, EEG, when there's abnormal head size, when there are seizures, and when there's speech regression. So seizures and speech regression, particularly in Landau-Kleffner syndrome. In some of the cases, you may have to consider a 24-hour EEG. Genetics. You are likely to have a good genetic cause when you have dysmorphism, abnormal growth, sensory impairment, unusual behavior, family history. Like I said, macro-array ECG, which I'll talk about in a second, is the gold standard. for myotonic dystrophy, there's a gene for that. And he also considers certain different tests for Angelman's syndrome and Prader-Willi, which are abnormalities on chromosome 15. The MRCP2 gene for Rett syndrome. So a girl that has the repetitive hand washing or hand mannerism and developmental delay and or intellectual disability, consider Rett syndrome. And macroarray CGH, if it's negative, you do the specific test for the MECP2 gene. In the UK, apart from the macroarray CGH, most units now carry out the whole exome through genome sequencing. Some units only have to ask for that through the clinical geneticists, but in my unit, it's part of our standard test. I'll talk about the genome sequencing in a minute. So the comparative genomic hybridization, that's the array CGH, is a standard test. Apart from those three conditions I picked out, it will pick out most of the chromosomal analysis. It is about 100 times the resolution of karyotype, and it identifies 450 genes, 400 of them syndromic and 50 non-syndromic. In the non-syndromic developmental delay or ID, the karyotype improves diagnosis by 3%. If there are no clear symptoms, no clear physical examination, but just developmental delay, doing a karyotype alone improves diagnosis by just 3%. Array CGH improves by 12%, and MRI increases by, image increases by 27%. The CGH array detects submicroscopic deletions and duplications in DNA with a size greater than 200 kilobase. And it does not identify Fragile X, the FMR1 gene. So if you see a boy, particularly with severe to profound intellectual delay without much clinical features, the commonest cause is likely to be Fragile X. So in the UK, we do the array CGH first. If the array CGH is negative and we still have concern, we suggest the child to Fragile X examination. It doesn't identify MEP2 gene. And after getting the result, the CGH array tells you about a copy normal variant. It can either be pathologic or benign. You request for parental blood sample. If this result is something that has arisen de novo, it's likely to be pathologic. If it's from the parent and the parent does not have any phenotype and the parent is normal, it's likely to be benign. Okay? There is a catalog, the Decipher catalog, that gives you the likely diagnosis depending on the array CGH result. The role of multidisciplinary teams. The preschool, school, and co, they help you with the diagnosis. The speech and language therapies are very useful when it comes to social communication and interaction difficulties or difficulties with receptive or expressive speech or abnormal speech. The physiotherapies, occupational therapies, educational therapies are also useful in part of the assessment and management. School support, special school, educational health and care plan in UK schools for those children that need extreme support, particularly with global delay, portage referral in place. Social welfare and safeguarding units come in when the child is subject to child maltreatment, and the neurologists are there to receive complex cases, particularly cases that involve neuromuscular system, where they might consider doing muscle biopsy, or neurophysiology of the muscles. Now, for the inborn errors of metabolism, the UK has a wonderful system where 7 different metabolic causes are screened on a 5-day blood test. We need to do that in Nigeria. If the parent is Black, or there's a family of sickle cell disease, the child is screened for sickle cell disease on day 5, screened for cystic fibrosis, phenylketonuria, isovaleric acidemia, and 4 other tests. I'll talk about the ID gene panel. Now, the whole genome sequencing is the gold standard of identifying almost as many as possible genetic abnormalities. When the CGH array, what the CGH array cannot identify, the intellectual disability gene panel R27 would identify in most cases. The R27 has 12 different panels looking at all the genetic conditions in childhood associated with disability. Most units request for it, but other units, you need only the clinical geneticists who have seen this child to request for it. Education support is very important. Special educational needs in those under 4, they go to the resource base where they have very, very high teacher pupil ratio. You have the clinical psychologists visiting. They have specialist teachers for the deaf, specialist teachers for the blind involved. They have individual educational plan. They have specialist provisions, educational care span. It will be interesting to see what kind of support we have in Nigeria for those children that you've made a diagnosis of global delay and intellectual disability. How many special schools are there? How many schools for children with learning difficulties? How many trained workforce do we have? What provision does the federal government have for this group of children? The SIN lab in Nigeria, located in Likweju, can do the following tests: cytogenetic bloods, can do karyotyping, can do tests for NF type 1 and 2, full gene, MPLA, and sequencing. I don't know whether this is the genomic sequencing. They can test genetic test for CMPND DNA and Neuboma genome wide testing. Recommendation: there should be training on development assessment I've sent some research material with video supplement to Dr. Eletu to distribute. There should also be hands-on training on ASQ3 and schedule of green skill, which are planned to demonstrate at the next at the pre-workshop next PAN conference. The Child Neurology Society of Nigeria is arranging to launch the child surveillance book for all Nigerian children under 5 years of age. And this should contain the developmental assessment carried out at various ages in Nigerian children. And there's a paucity of clinical geneticists. The federal government should employ clinical geneticists and encourage pediatric resident doctors to go into that specialty. There should be the establishment of genetic labs that can do CGHRA and DNA tests in each geopolitical region in Nigeria. I think it may be beneficial to have an MOU between the Bristol Genetic Regional Lab and an institution in Nigeria to improve genetic testing in Nigeria. What are the limitations for investigation, genetic investigations, cost of investigations of development delay? Cost, they are too expensive. Paucity of laboratory carrier DNA investigations, inadequate number of clinical genetics workforce, risk of general anesthesia in children under 5 years undergoing MRI because we don't have many pediatric anesthetists, and poor yield of many of these tests, as Dr. Hart's study in Children's Children's Hospital would demonstrate. Conclusion: early identification and management of developmental delay and intellectual difficulties improve outcome. Children with mild developmental delay do not need investigation. They only need careful monitoring. What do you call it? Careful surveillance. Meticulous history and examination will identify a large number of the children with moderate and severe developmental delay and intellectual disability. Genetic investigation will improve the etiological diagnosis of these cases. RACAG and ID gene probe and exome to genome sequencing are the gold standard in genetic investigation of DD and ID. References: etiological investigation, early developmental impairment, guide to the investigation of intellectual disability, assessment and investigation of the child with disorder development, genetics and investigation of developmental delay, and a practical guide to assessing and investigating developmental delay. Symposium, Neurodisability. I'd like to thank Dr. Femi Mobolaji Lawal, who I just wanted to be like, I copied him. Thank you for getting me into the specialty of pediatrics. And I also thank Dr. Shende Eletu. I applied to be the Royal College of Pediatric Regional Advisor at 33,000 feet above sea level. Our closing time was 5 p.m. We were in the flight from Sierra Leone at 3 p.m. He helped me to upload my application and it got to the college by 3:15. Daddy, thank you, Cindy. Thank you.
Thank you very much. I think we all agree that this has been a brilliant presentation. It deserves a round of applause. You can do that electronically and you can do that physically. In the past 45 minutes or thereabout, Dr. Tare has gone through definition of terms, the burden of the disease, of the conditions in Nigeria. He's looked at clinical features. He's also talked about first-line investigations that should be done, second-line investigation, highlighted the need for genetic studies, and rounded it up by providing us with recommendations. I just want to thank Dr. Bio again for bringing to our consciousness this issue that has been a problem. Let me just start by saying that from the federal government perspective, the federal government currently is working assiduously to getting a national strategy for the healthcare of children with special healthcare needs. That will include children with neurodevelopmental disorders. Before the end of the year, that national strategy will be out, and it will increase access of the Nigerian child, to healthcare services to address neurodevelopmental disorders. So I would just welcome the comments, one or two comments or questions in the chat box for Dr. Tare as we bring this presentation to a close. So comments, questions, please, let's go ahead.
Oh, sorry. Sandy.
Yes, ma'am.
I sent a question to your box directly for
okay.
Please,
okay, let me check.
Help me read it out. Thank you.
Okay.
If you want me to do it, the question, thank you very much, Amabatare.
I can't find it. Please go ahead.
That's okay. Thank you very much, Amabatare. That's a beautiful presentation. I enjoyed every second of it. I just have two things I would like to ask you. They're not, I just wonder if you could signpost us to a dermatology picture book that will help us Black skins to recognize the skin rashes you talked about. Do you have any idea of a dermatology Black picture book that would help? That's, for us to use as our reference. It's easy to see it on the white skin, so I just wonder if you could help us with that. The second thing I wanted you to speak to is, in our environment, we should be focusing on prevention, because we do not have all these systems in place that you've talked about, and they are wonderful systems. There's no doubt about it. I just wanted you to talk a bit about the role of genetic counseling in prevention, if you could address that for me. And there was something else I wanted to mention. The ancient ones amongst us know that in Malaysia there was that, is it road to health? That was very useful when we started pediatrics. They fizzled out. Is that what the Neurologic Society of Nigeria is trying to reactivate? Those are my three questions and comments. I'm sure Dr. Mobolaji Lawal will be able to talk about this road to health chart developed by this man in Elisha, this Oyibo man that was practicing pediatrics in Elisha. I forget.
Molly.
Thank you. The man that wrote the pediatric.
Yes.
Thank you. Thank you very much. Those are my three questions. Those are my two questions and comments. Thank you.
Okay, sorry, Senior Elizabeth. Your question on Elizabeth was my senior in A-level.
Senior.
Okay.
Your question on genetics, it wasn't very, I didn't hear it clear.
No, I just wanted to know if genetic counseling will be useful in prevention,
Yes.
You know, because you talked about consanguinity, you talked about, you know,
yes.
Siblings, you talked about all of those.
Yeah, okay. Let me start with that aspect. Usually, when we get a genetic diagnosis, we refer the patients to the clinical geneticist. We have them many. We have them many here. Particularly when you do the array CGH, you get the parental, get consent for the parental bloods. So if the parent, any of the parents is positive with the CGH array, and the parent is not phenotypical, so the deletion is likely to have occurred de novo, in which case it is pathogenic. It is pathogenic. So the clinical genetics will discuss the risk of future pregnancies having that, and the prognosis of the child. So we send them with clinical geneticists, and that's the drawback we have in Nigeria. I spoke to 2 eminent pediatric neurologists in Nigeria. They don't think we have a clinical geneticist. I don't know whether that is true or not. For any of those children with a genetic diagnosis, they need genetic counseling. So apart from getting the clinical geneticists, you need the genetic counselors, you need the genetic nurses, you need the genetic residents. And that's one thing the Child Neurology Society of Nigeria and your group should take up as a matter of urgency. What was your first question again?
That had to do with a reference for skin rashes.
Yes, actually, there are some dermatology books that have many black pictures. I'll look for that. And there's a dysmorphology book. I'll also send the list to Dr. Eletu. With the dysmorphology book, you can have it in your clinic. So when you see the different morphological problems, quickly open the pages and see the one that's closest to it. And for the CGH array, there is the Decipher catalog, which the clinical geneticist uses as well there. So far, doing the karyotype looks like what is available for, in most laboratories in Nigeria, and it yields just only 3%. We need to get labs that do more than just karyotypes, at least one in each region, so that samples can be sent there for analysis.
So thank you very much, sir. I will just make 1 or 2 comments concerning the issue of what the Child Neurology Society of Nigeria is doing with regards to child neurodevelopmental surveillance. Yes, so the book that a group is working on to be presented by the society has to do with, it has all the trappings of the Road to Health chart, but it is much more interactive. In other words, interactive with the parents, particularly the primary caregivers, should be able to answer very basic questions, not just to be marked when they visit the institution, the health institutions. So hopefully we should get that ready and to present that in January. I also want to state that, like I said earlier on, the strategy to address the health of children with special healthcare needs is looking at supporting, that's from the federal level, supporting health institutions with developing capacity to be able to identify some of these conditions. The recommendations Dr. Tare has presented here will form an important part of the final document that will come. We'll make sure that they are incorporated in that document. So once again, I want to thank the Guild for this wonderful opportunity, and I will yield back to the chair of this occasion. Thank you very much, sirs.
Thank you very much, Dr. Tare. Thank you, Edwin, for a wonderful presentation and for the moderation. Well, let me also especially thank Dr. Biu, because I remember on that flight when we were putting that document together, we had fun on the flight, and I'm so happy that you got the job. You've done a very fantastic job. At least we're aware that a few residents from the sub-region have been to the UK to learn a few things, and they are back to improve care in their various institutions. So I say big thank you, and I'm looking forward to us doing another, sending another document at 33,000 feet above sea level.
Thank you.
Thank you. So I want to yield to the chair, Dr. Mubolaji Lawal, for a few words before we close. Thank you very much, sir.
Okay, yes. Thank you, Sandy, for the meeting, and thank you, Professor Esegbe, for ably moderating the session. I thank Dr. Biu for the very nice things he said. I think it was fortuitous that our paths met 42 years ago, and I'm so proud and so pleased of what you have become, and you have broken boundaries and achieved so much, and for the excellent work you are doing, not only restricted to pediatrics in the UK, but trying to give back to Nigeria and coming back and helping the organization to set up so many things. We are very proud of you. Please keep it up.
Thank you, sir.
I acknowledge also the presence of Professor Grange at this meeting. He's revert all the way from the US. Thank you, Ma, for joining us. Concerning David Molly, while he was working at Elisha, was very instrumental to many innovations. And one of the road to health chart, he was concerned about the weight of children. And the important thing is that he first thought about the idea that the parent should hold the chart. And I think that was the most important thing about that. Previously, records were being kept in the hospital. So he felt that the parent or the caregiver must hold that chart. And it is based on that single innovation that many other charts, I think even including the Red Book and some of the other books have been developed. More things have been added. And I'm so happy that the neurology group is coming up with something that will be close, if not the same thing to the Red Book in the UK. On that note, I want to thank everyone again for attending this meeting. And I'm very encouraged by the large attendance at this meeting and what the yield is in terms of what is coming out of these meetings. So thank you all very much, and have a good day. Over to Dr. Elitu.
Thank you very much, sir. Once again, I want to thank each and every one of us who joined. Also to say a big thank you, because we had close to 90-something participants at this meeting, which is quite encouraging to us. The video as well as the book that Dr. Tare mentioned, we posted it twice on this forum, and it's been posted to all our social media handles, so we can always check on the 30th of November for another meeting and another interesting discussion. Thank you so much, Dr. Biu. Thank you, Professor Esegbe. Thank you, our able chair, Dr. Mubolaji Lawal. I want to thank all the participants. God bless you all. See you next month. Bye for now.
Thank you. Thank you.
Okay. Bye.